Hello and welcome to Lessons My Patients Taught Me, the podcast where we explore the people, experiences, and lessons that shape us as healthcare professionals. Before we get started today, I want to dedicate this podcast to the memory of Lisa Powers, my mother-in-law, who recently passed away since the last podcast recording. Lisa was a wonderful mother-in-law, a wonderful mother, grandmother, great-grandmother, friend, and amazing person. She was very interested in this podcast, a loyal listener, and a wonderful promoter of the podcast. She would have been very interested in this particular podcast because she was very interested in medications as a chemist, and she had a lot of other wonderful attributes and will be missed very much by me and by many, many other people. Today, I'm joined by someone our residents know well and someone I've had the privilege of working with for many years, Dr. Jim Ferrell. Jim is a clinical pharmacy specialist at Cleveland Clinic Akron General, assistant professor at Northeastern Ohio Medical University. But those titles only tell part of the story. Jim has a unique background that spans basic science research, pharmacy, education, and patient care. He received his PharmD at NeoMed and his PhD in physiology and microbiology at Kent State University. He's a published author, inventor, researcher, educator, and one of the most trusted medication experts I know. Most importantly, he's become an invaluable member of our residency team. In fact, our residents recognized his impact by naming him Teacher of the Year a few years ago of both his expertise and his commitment to helping learners grow. Today, we're going to talk about something that affects virtually every patient we care for, medications. We'll discuss the partnership between pharmacists and physicians, why medication reconciliation at hospital discharge is so important, and some practical ways we can help patients and families better understand their medications, including how to take them, what side effects to watch for, and how to avoid common pitfalls. We'll also explore an innovative project that Jim is leading to help clinicians select inhalers that match a patient's abilities and needs, an example of how thoughtful, patient-centered care can improve outcomes. One of the themes that comes up repeatedly on this podcast is that great healthcare is a team sport. Jim's career has been built around helping patients through collaboration, education, and a commitment to getting the details right. Jim, welcome to Lessons My Patients Taught Me.
Pleasure to be here with you tonight, Elliot. I've been looking forward to having this conversation with you.
Jim, now you've worked as a scientist, inventor, educator, and clinician, a lot of different roles. Talk about your journey and what each role has taught you.
Yeah, that's a great question, Elliot. So one of the things I've had the privilege of doing is, as you mentioned, go through several roles in my life. And I would say that the thing that combines all of them is innate nature to learn and grow. Even as far back as in my childhood, through my adolescence, I've had healthcare professionals working in my family. My mom worked at Akron General for a very long time. My cousin, Dr. Eric Kolb, was an emergency medicine physician and even to this day does a lot of work with NeoMed. So I've had the opportunity to really look at healthcare as a profession. And thinking about what I wanted to do with my life, it came down to figuring out what really resonates with me. And I was always very good with sciences, and I had the opportunity to explore research as a career early, even as far back as an undergrad. And from there, I was able to take this biotechnology concept into graduate school. It kind of spun out from a summer research project. And from there, it explored biotechnology, antimicrobial therapy, wound healing. It was this really great concept. And I was really able to take that and explore it at Kent State for my PhD, my doctorate work. And from there was actual commercialization opportunities. And I had the privilege of working alongside of Joe Canfer at Gojo. And from there, I explored different technologies, different applications with a lot of other brilliant scientists. And it was a very exciting time to be able to apply something that you've spent so much time with, seeing how you might be able to take that concept, patent it, explore the commercialization part of it, the legalese behind it, all the patent work. And I had a lot of opportunities to really learn, and I'm very grateful for that time in my life. However, one thing I found was difficult for me to see some of my work not be able to make it. And even the great ideas would end up in a binder on a shelf if it wasn't commercializable enough, if the patent space wasn't there. And so it kind of left me feeling a little bit unfulfilled. I wanted to help people. That was the point of my research, my work. And it just didn't resonate with me as time went by. And like I said, I'm very grateful for those opportunities, but I had an opportunity come my way kind of unexpectedly where I could explore Neomed, and I had some friends and some people that were working at Neomed at the time. So I had a chance to kind of pick their brains and learn a little bit more about the program, because as I was deciding between research and even pharmacy, that was a path I almost took years before. So pharmacy was always something that I was also interested in from a therapeutic standpoint. And reaching back out to some of my old connections, I explored the opportunity there. The timing worked for me, and I took the leap. And it was a very stark change going from working in private industry, stepping all the way back, working in community pharmacy. And it was a big change. I had a lot of people help support me along the way. And then as I progressed through Neomed and my training, I had the opportunity to try to figure out, what do I want to do with this? Pharmacy has a lot of different places that you can practice. I think most of public perception is pharmacists are behind the counter counting pills. And one of the things I wanted to do with my journey was explore all the different things that pharmacists can do. And so I was very fortunate to have some really great mentors at Neomed. I had some very great clinical experiences, including even work I did here as a pharmacy student at Akron General. And it was really working with some of my patients as a student that helped me have further insight into working in a hospital setting, working with clinicians directly, and really always being interested in learning myself. I always had a desire to pay that back and to teach. I wanted to try to give that back because I felt like being a teacher, being a clinician helps keep my own skills sharp, and I can also learn from others as I'm going.
Was
Yes,
there a
that's
particular
a very, very good
patient or
question,
experience that
Elliot. I
convinced you
had the
that direct patient care and education was where you wanted to focus your career?
Yes, that's a very, very good question, Elliot. I had the opportunity to work with a patient even as a student. And this is really what helped crystallize the fact that I wanted to pursue hospital pharmacy, because I still wasn't sure, even into my final year of clinicals. And I had an opportunity to really work in detail with this patient, had severe heart failure, severe COPD, uncontrolled diabetes. And I really spent a lot of time with him and helped him put together a treatment plan, counsel him, get his buy-in, and that was very powerful for me because of seeing how sick this patient was in the hospital, and then being able to help facilitate all of his needs and coordinate all of his follow-up and solve his barriers and answer his questions, and to see him do so much better over time, that really, like, crystallized for me, this is what I wanna do. This is why I do this is why I do the things that I do. This is why I stepped away from biotechnology. This is what I was missing. And I think it was that moment that really shaped the future of my career.
Now, you were selected as Teacher of the Year by the residents, and I'm wondering what makes teaching residents and students so rewarding for you.
First of all, I work with a lot of really great clinicians, yourself included, over at Family Medicine, and I'm very blessed to be part of a faculty that has a wide breadth and depth of experience. And to win that recognition was very flattering. I actually have the golden apple sitting on my desk right in front of me right now, so it's a reminder to me to continue to work towards getting better as a clinician and a teacher. Because the reality is, our residents and our faculty teach me. No two services are the same. No two resident pools on rotation with the attendings are ever the same. So the dynamics are different. The learning environments are a little bit different. And it's really an opportunity for me to not just pass on my clinical insight, but also to try to help shape and focus the direction of our team on the inpatient side. And that is very gratifying for me as a pharmacist playing a role as part of this interprofessional team. So really watching the residents grow and develop is very rewarding. There is no higher sense of gratitude that I have than to see a resident be able to remember or teach somebody else something that I've taught them. And so it really it speaks to the paying it forward, really making sure that they understand and can really apply what I've taught them.
What are some of the medication-related mistakes that you see learners making repeatedly, and how do you help them with that?
That's a really insightful question. But as far as specific medication errors that I see, and I really emphasize a lot, insulin is a big one because I think about the high risk potential with something like insulin and really making sure patients understand, but also making sure our residents understand the differences between high risk medications like insulin products, how you adjust them, how you monitor them, how you apply, how you make switch. And that is something that I really focus significantly on. I would say another class of medications would be blood thinners because they have a risk to harm patients. So there's really a focus on high risk medications like insulins, like blood thinning products to really make sure our residents understand both the inpatient, outpatient, and long term follow up. Patients can have new medications come and interact with their blood thinners. Patients can lose weight. They can have changes in their kidney function and that can affect their insulin dosing. So these are things that I try to make sure our residents understand very clearly because of the potential for harm over time.
Tell us about what medication reconciliation is, what happens when somebody leaves the hospital, and how that helps prevent a serious adverse event from medication.
Sure. One of the things that pharmacists do in this setting is when a patient is hospitalized, we look very closely at their medication list. I like to tell my students, my pharmacy residents, that pharmacist roles for our patients in the hospital is we own the medicines. We work closely to understand the disease process. We're not diagnosticians. We are there to help support our medical colleagues, but we are there to own the meds. That is our role. We are there to own them when we start them, stop them, monitor them. And so I take the ownership of medications very seriously. So it starts when a patient comes into the hospital and looking through their medication list and talking with them. A good amount of the information I can find from the chart, from their fill history, from the notes, all of that. But actually sitting down and talking with the patient to understand how much they understand and how they take their medicine goes a long way to figuring out how do we best treat them now and in the future. And it really comes down to doing a really good job at the beginning to help make sure that as the patient gets closer to going home, that you've done your due diligence. Sometimes you're like a detective. You're figuring out things that don't make sense. Maybe this is an old medication, but you make sure that you do the best you can and make so that the patient understands so that if a medication change happens, you can put together the best treatment plan both now and in the future. And then as an example of a time where I caught a very significant drug-drug interaction was a patient that was on a blood thinning medication and an anticonvulsant medications. And these two did not mix very well. What would happen would the seizure medication and the blood thinning medication basically offset each other. So you had a patient that was using a seizure medicine that could weaken the effect of the blood thinner and vice versa. So this patient was on two medicines that didn't mix well together and were both being affected by each other. And so when you come across a situation like that, you work with the team, you work with the patient, and you put together a new treatment plan. So that way the patient isn't at risk for having a blood clot, isn't at risk for having a seizure. You take care of the patient then and in the future.
Tell us what medications cause the most confusion after discharge from the hospital.
Well, one of the things I found is patients that have been in the hospital for even a few days, it's very disorienting. They're not in their home environment. They are not in their home. They're not in their home environment. They're not eating like they usually do. They're not interacting with people like they normally would. And it's just one of these very disorienting times. And so maybe there's some confusion. There's some just physical weakening from being in the hospital, and comprehension may not be as high due to being sick, due to having issues with breathing, or having a bunch of fluid taking off of you from a heart failure issue. And it's a really dangerous, delicate time for patients, especially if a patient is going home on 3, 4, 5, 6 plus new medications. It would make anybody's head spin. And when you have that many changes, you have to think about how much the patient can retain and understand. What does the home life look like? How much support does this patient have? Does this patient have somebody to help them? Does patient have the ability to draw up insulin? Does the patient have the ability to use their new inhaler? And so this is the high risk for these patients. And so it comes down to trying to put the patient in the best situation that you can and understand where they're coming from and meet them as far as you can. And I think doing that helps give them support. Our team does a really great job facilitating follow-up appointments in the outpatient setting to continue to make sure they're doing the right thing, that they're understanding. But I think at that time, depending on what brought the patient into the hospital, that disorientation, that weakness, that haze from being in the hospital can make even baseline understanding more challenging. And I think you have to factor that into patient care. I kind of alluded to insulin. That's one that I really focus a lot on. Also inhalers, insulin inhalers, those are two, I guess, classes. Really, it comes down to making sure patients understand that there are different types of insulin. I try very hard to make sure that we don't send a patient that's never been on insulin on multiple types of insulin at discharge, so that way they're more successful. I also try to make sure that patients, if they've had issues with breathing, that we get them set up with an inhaler that they can use, and really just making sure that they understand the difference between emergency treatment and treatment that you use every day. And it really comes down to meeting the patient where they are and helping them see, and whether that's through demonstration, whether that's through videos, whether that's technique, all of these are strategies that I've used to help our patients see that they can use these medications safely and take ownership and power of their health. And I think there's something very rewarding about watching a patient's recognition light up. Like, oh, I can do this. I can do this. I understand what you're talking about. And maybe taking away some of that unease, that fear, and giving them power over their own health, in my experience.
What questions should patients or families always ask before they leave the hospital?
It's actually a very underestimated or underused aspect of my job. Is there, I think, is a perception that patients cannot ask clinicians for help as much as they probably should. And I think that there's some intimidation about asking your local pharmacist or asking, your doctor, or being as candid depending on the relationship that you have, in my experience. And I really wish that our patients would ask me more questions. But when they do, I want them to understand that I am not in the business of just throwing medications at them. I'm looking very closely for opportunities to pull medicines away. I'm looking for opportunities to make sure that medications mix well together, so to speak. I'm wanting them to ask me, are these medications safe? How do I understand these medications? How do I organize these medications? What do I need to know about how to manage these medications? These are the sorts of things that I can answer for patients in a patient-friendly way. But I think there is an intimidation that maybe clinicians might have in the minds of some of our patients that, well, that's just what the doctor tells me to do, so I do it. But I really try to encourage empowerment, whether that's with my students, with my residents, with my patients, with my colleagues. I don't know everything. I'll be the first to admit it. And I really want the people that I come into contact with to ask me questions, because it's my job to do the best of my ability to answer those questions.
Now, you've been working on a very interesting project called the Inhaler Assessment Project. Tell us about that project and how that helps patients.
Yes, thank you. That's something that I've been working on for quite some time. And it really kind of evolved as an observation and a discussion that I had with our other fantastic pharmacist, Dr. Megan Adelman. There's a tool that you can use typically in the outpatient setting that lets you assess a patient's ability to use their inhaler. And basically, to sum that up, you have this device, and this device can be calibrated or adjusted to mimic the amount of physical resistance that a patient would need to have to overcome, I should say, to be able to use this inhaler appropriately. I can then have them give me a physical measurement by giving me just a breath. And sometimes I'll have them give me one, sometimes I'll have them give me two or three, depending on what the measurement says. And I can then see, based on this reading that I get, can they use their inhaler from a lung function perspective? Not just can they use it in their hands or use it on their mouth, but actually can their lungs activate enough pressure or force, so to speak, to be able to get the medication into their lungs where it can work. And so it kind of spun out from a outpatient perspective to, this patient is here in the hospital for a COPD exacerbation. Let's look at potentially switching this inhaler that may be more difficult for them to be able to physically use to something that may be easier for them to physically use, and then teach them how to use it. Show them demo devices, videos. I'm very lucky to have the support of our outpatient pharmacy. There are fantastic clinicians and technicians that do a wonderful job supporting that program. I wouldn't be able to do the things that I do without technicians like Krista, Kiana, Matt. There's a lot of people that help me in this project. But what I'm trying to do is give pharmacists throughout the hospital this same technique, this same equipment to be able to touch more patients, because I've been able to help our patients obtain better quality inhalers, overcome cost barriers, and I'm trying to expand this concept into a more hospital-wide effort.
Now, how should physicians think differently about selecting inhalers? For example, what role do manual dexterity, cognition, strength, inspiratory strength, how well they can breathe in, and health literacy play in the choice of an inhaler? As you know, this
Yes, this is one thing that I really speak to our residents about within the scope of the clinical guidelines, because that's the other thing too that we don't really talk about is there are changes in the way that our guidelines direct therapy, whether we use certain types of medications, do we use certain combinations of medications, how do we put them together. Ideally, if we can take a patient that's on 2, 3 inhalers, including the rescue inhalers, and condense that to 1 or 2, it makes a adherence standpoint much more effective. Cost, because a patient may be only getting 1, maybe 2 inhalers instead of 3. So that makes the patient happy. And it comes down to which types of inhalers fit your patient best. I always kind of think about it as like Tetris or a puzzle. There's a hierarchy in my experience of using certain inhalers based on lung strength, and maybe the easier inhaler from a lung strength perspective may require more dexterity. So if you have a patient that is limited and is limited from a dexterity standpoint, then there's another inhaler that I would use. So it really comes down to fitting the type of inhaler to that specific patient, their cognition, their lung physiology, and the overall treatment goals for that person. And this is one thing that I try to drill into the residents who are on service with me. I usually will do the inhalers and COPD on my inpatient block with them. I know my counterpart, Megan, also does a fantastic job with this, but the goal I have is to make our residents and our clinicians see is that in this sea of inhalers, that there is a difference in how a patient may be able to physically use an inhaler and be able to physically absorb the inhaler, the medication, into their lungs. I even did this today for one of our patients.
podcast is called Lessons My Patients Taught Me. What lessons have your patients taught you over the years?
It's actually a really insightful question. I think going back to the example I had with the patient that I worked so diligently with as a student, I try to capture that and remember that, because there are times where it is challenging to work with a patient that for whatever reason cannot adhere to the regimen, whether it's cost, whether it's other issues such as addiction or lack of supports. We as clinicians, beyond just treating disease, we also have to overcome a lot of social barriers. Patients aren't able to get medications for a variety of reasons. Costs are huge. Getting to appointments are a big deal. So I think it comes down to being mindful that this is a person and not a chart. And that's something that I try very, very hard to always remember every day that I'm working with my patients. This is a person that has very real other things going on at home. They may have to decide between whether they eat this week or get their new inhaler. And I think that perspective is very humbling and very powerful for clinicians. And it motivates me to figure out ways that I can make their life a little bit easier. I mean, I come across these situations almost every week, these social barriers, and trying to figure out how do we best treat this patient and make them able to be set up for success. And I mean, again, trying to capture or recapture that spirit of this is a person that if you give them the tools and give them the time and be patient and diligent and steadfast, that there are significant success stories that can happen. And I think even more than that is if you have residents, students see and experience that, it teaches them and they can then carry that into their practice. And so that is something I try to carry in my clinical practice.
I'm also wondering what lessons physicians out in practice and residents have taught you over the years.
Well, as I mentioned, I'm very blessed to be part of the department. Even as a quote unquote outsider, since I'm not physically in the clinic, I've always been included. And that goes a long way to basically working as Megan's counterpart and really making sure that that connection between she and I, if I'm referring patients to her, or making sure that our colleagues know that I'm available also. And I've been able to really understand different teaching styles, different ways to approach medicine. As I mentioned earlier, I'm not a clinician, or I'm not a diagnostician, but to understand the way that different clinical faculty members think about diagnosing disease, how do they process, what is their experience or their insight into medication management? Because the way that I've been taught something does not mean that that's the way that somebody else's experience is. And how can I learn from them? And I think, as somebody, as I mentioned earlier, that is always looking to learn and experience new perspectives, it allows me to sometimes bridge gaps or to come to a collaborative decision that maybe, if I were to say, I would recommend that we do this, but a clinician says, well, I think we should do this. So then we cross that bridge so we both understand, whether that's looking at guidelines that have changed, and then we both learn something. And I think that's the really powerful part of working with such a dynamic team, both the clinical faculty members, the physicians, the PAs, the nurse practitioners, the nurses in our office, and our residents, because it's a very ripe environment for learning, adapting to our patients' needs.
As you know, I love medication related pearls. In an earlier podcast, I talked about doxycycline being the number one cause of esophageal ulceration. And I also talked about Medrol dose packs being way too short for treatment of severe poison ivy. People often get rebound. What are some of the medication related pearls that you think every listener here should remember after today's conversation?
That's actually a really, really good question. Most of my favorite medications are around antibiotics. I think that when you start any medication, doesn't matter how long it is, whether it's a course of a steroid or an antibiotic, you should always think about how that medication may mix with others. So be mindful about when you have something new to, again, this alludes to what we talked about earlier, is if you have a question about something that seems as simple as an antibiotic or a steroid, what may this be doing to my other medicines? And being able to ask and ask confidently, because you never know what that supplement that you pick up at Walgreens or Walmart or CVS, how that might mix with your blood thinner, for example. And so I just want patients to understand that your doctors, your pharmacists, they are looking out for you. And if you have questions about whether something is going to be right for you, or what this might do to your other medications, or how this might impact your goals, just talk to us. Just talk to us. That's something that I really want listeners, learners to really understand, is that as much of a collaborator that I have with my colleagues, I look to be more so to my patients.
What has surprised you most during your career journey from scientist to pharmacist?
Wow, that's a really good question. What I would say is there's really, I think, no limits to what you can explore, regardless of starting out in one career path versus another. If you keep an open mind and keep an open perspective, and you pursue something that really means something to you, I'm very grateful every day because I'm able to do something that I genuinely love to do. And I think if you keep an open mind and you approach the things that truly matter to you, that carries over into your work, that carries over into how you interact with others, whether that's your colleagues, whether that's your patients, whether that's just somebody that you're passing on the street. That mindset that I can learn something from anybody today, and it doesn't matter what I've done in the past, it's all interconnected. I may not use my benchtop research anymore, but I still use my ability to read scientific literature. I still use my ability to perceive data. I still use my ability to analyze a treatment plan. So just because one chapter of your life may change, you can still carry over different aspects of those former chapters of your life and really write a new story. And I think that is something that's very powerful about working with patients, working with learners, and working with other clinicians, because everybody has their own story, and you have the ability to take excerpts and fill in your own chapters as you keep going. And I think that's something that I will carry over, and I encourage my resident learners and my students to think about is, are you learning today? Are you 1% better than you were the day before? And how does that carry over into the goals you're setting?
Thank you so much, Jim. It was great having you on today, and I really appreciate all your insights about pharmacy, teaching, and many other things. I found this a very enjoyable conversation.
An absolute pleasure to share a little bit more about what I do and kind of my experiences. Like I said, it's an honor to work with you and the rest of the other family medicine physicians and our residents. So I appreciate the time and the opportunity to have this conversation this evening. You're welcome.
As we wrap up today's conversation, I'm reminded that some of the most important members of the healthcare team are often working quietly behind the scenes. Dr. Jim Ferrell has shown us that medications are much more than prescriptions written in a chart. They represent opportunities to heal, but only when patients understand them, can access them, and can use them safely and effectively. He reminds us that the best healthcare outcomes often come not from a single clinician's expertise, but from a team of professionals working together on behalf of the patient. Successful healthcare depends not only on choosing the right medication, but also on helping patients understand why they're taking them, how to take them, and what to expect along the way. Jim, thank you for your dedication to teaching, to patient safety, and to improving the care we provide every day. And thank you to our listeners for joining us for another episode of Lessons My Patients Taught Me. Until next time, keep listening, keep learning, and never underestimate the lessons that patients and our colleagues teach us every day. And stay healthy out there.
The preceding podcast contained discussions of medical cases where names and identifying details were altered to protect the privacy of individuals. The views and opinions expressed were those of the individual speakers and do not necessarily reflect the official policy or position of any affiliated institutions or organizations. This podcast was for entertainment purposes only and should not be taken as medical advice.